Now I begin my presentation with this slide to remind all my colleagues, especially the junior colleagues, that 80% of the fractures of the proximal humerus are minimally displaced and they do very well with conservative treatment. So don't start operating on these. Here is an example. To me, it doesn't matter whether it is 4-part, 5-part, or 40-part. What matters to me that it is minimally displaced. This is a 64-year-old lady, mother of a gastroenterologist colleague. I conserved it, and this is the result at 6 months. And this is how the proximal humerus fractures will behave in 80% of cases. Why? Because they are minimally or undisplaced, and they do well with conservative treatment. Point number one. So the real challenge is the remaining 15 or 20% of displaced fractures. And they are the ones which are a real challenge to get a similar result. And we have a whole list of treatment options available in the world market. And I'm going to present to you the results of a very unique device, which is an intramedullary device called the Just Unique. So first we must accept, and I hope that my friends in Brazil also have a similar experience, that there is a problem with the current available methods of open reduction and internal fixation. Let me share some of the experience here in this part of the world. Example one, a 73-year-old gynecologist, looks like a simple straightforward fracture. Somebody did a plating, a locking plate, and this is what happened. And I bet that all of you have come across such examples. Example number two, 66-year-old male, 4-part fractures. The tuberosities are flying, and naturally, this patient has a poor functional result. Example number three, an exotic kind of fixation. It was a day one failure and it failed. And this is what it looks like after removing the implant. Example number four, again, a unique kind of tension band wiring failed. And example 5, 6, 7, 8, 9, I can go on and on the whole day with plating and failure. Now let's look at the international, this trial, which is infamously famous, the Ortho trial from England. And what they said is that whether you operate or you don't operate on proximal humerus fractures, the result is the same, which shook the world. Now let's look at this in proper perspective. I think it was a faulty trial. They reported 250 cases, and kindly note, gentlemen, they had 18 1-part, 128 2-part, and 104 3 or 4-part. So it's all mixed together. How do you interpret such a study? And more importantly, what the Ortho trial reveals, that it's not that the results of conservative treatment are very good. It basically implies that the results of internal fixation are so bad that even if you don't operate, the result is the same. So it reflects the poor results of internal fixation as it is today. So why is this such a difficult fracture to fix and plate? There are many reasons. The top three to me are that the head fragment is often a shell with osteoporotic bone, very difficult to have any screws with solid purchase, and the tuberosities are difficult to fix and retain in the position. And this effectively leads to either a tuberosity non-union, malunion, or a resorption. The head fragment often falls into varus and with the avascular necrosis of the head. So to me, in this proximal humerus fractures, the 4-part displaced fractures are a real challenge. Plating has shown some reasonable results when it is a 2-part or a 3-part. But the real challenge to me is the 4-part displaced fracture and a fracture dislocation, which is hard to get a good result with consistency. So the world started doing hemi in 4-part fractures. This is hemi example number 1, tuberosity gone. Hemi example number 2, done by somebody in this part of the world, again tuberosity gone. This is my own case, number 3, tuberosity resolved. This was a failed fixation, which I did a hemi. So therefore, there is a problem with hemi as well. This is not just my opinion. There are many studies which show that hemi arthroplasty in 4-part fractures, the tuberosity will misbehave in as high as 50% of cases. That is very high failure rate. And if the tuberosities do not heal, then you're bound to have a poor function. Now, my understanding after 25 years is these fractures are not doing well as of now with the current available methods of fixation, because there is a failure in basic understanding of the biomechanics, which Professor Kahera nicely displayed by his method of explaining between impacted and non-impacted. But our understanding of the biomechanics of the proximal humerus is not proper, and therefore we need to innovate. Innovation is necessary. And this is what I present to you, ladies and gentlemen. This is the intramedullary device. If you see, there is a circular staple. This staple goes inside the fractured head, and there is a stem which is intramedullary. The stem has a sleeve. You can increase or decrease the height of the stem. What very importantly was brought out by Sergio, that it is important to maintain the height in these fractures to stop the head from collapsing and the screws cutting out as a result. So this collapsible or extendable sheet allows you to maintain the height or achieve the appropriate height for the tuberosities to reduce in its anatomic position. And the stem fits into the staple by a Morse taper, and the stem is uncemented. This is the Bilboquet concept, first thought of by Professor Dorzonian, a dear friend from France. So here is some examples. A 45-year-old male, a horrible fracture, you can see that. And it is a 4-part, like I said, it doesn't matter 4 or 40, but it's a displaced fracture. He also had a vascular injury. So I brought in a vascular surgeon. He put a graft there in the brachial artery, in the axillary artery. And we did the just unique implant. This is 6 months post-op. I challenge you, you show me a result like this that is possible with plate with a vascular injury. He has almost 100% shoulder function. And lo behold, the head has not undergone avascular necrosis. He is now 3 years post-op. Example number 2, 68-year-old right-handed male, displaced fracture of proximal humerus. Again, I did a just unique implant. Like I said, you can either extend the stem or shorten the stem because of the sleeve, which locks in with a screw. And by adjusting the height, you allow the tuberosity to fit in an anatomic position, which is critical. And the implant successfully maintains the height of the proximal humerus, allowing the tuberosity to sit anatomically. It is very simple and easy to do this operation. 8 months post-op, this is the result. United with excellent shoulder function. Example number 3, again a displaced fracture. This operation is done with a image intensifier, C-arm under fluoroscopy. And this is 8 months post-op, constant score of 96, no avascular necrosis. Example number 4, this is like a head split fracture. Not an ideal case to do this just unique implant. But I started becoming so comfortable with the implant that I went ahead, and though it is a head split, I managed to put one prong of the staple into that small fragment and the remaining into the large head fragment. And here is the result at 10 months. Again, no avascular necrosis. The head split has united, the tuberosity has united, and he has a constant score of 90. Example number 5, that's the same case I showed earlier. Somebody did a rush nail with tension band wiring. Naturally, this had to fail. I removed everything, put the Just Unique implant, and again, that is the result that you see over there. Now, I will show you a failure with this Just Unique implant. The mistake I did is this surgery can be done with two approaches. One is the superior Mackenzie approach or the deltopectoral approach. And usually I did the superior approach and I opened the shoulder using the superior approach, and I therefore realized that I am unable to fix that butterfly fragment that you see in the shaft of the humerus. And hence, that's the butterfly fragment you can see on that X-ray, the AP view, which I left unfixed, leading to an unstable stem, and therefore the surgery failed. So from now on, whenever I see that the fracture has extended into the shaft, I would recommend and suggest that do a deltopectoral approach so that you can fix that fragment with whichever method you want, whether it's a cerclage or an interfrac screw or whatever, but you can stabilize it. Or do not use this implant if you feel that the stem is going to be unstable. The stem is supposed to be uncemented. So naturally, I had to revise this and I did a reverse shoulder arthroplasty. So here is my experience. This is accepted for publication in the Journal of Shoulder and Elbow Surgery. That is the DOI number, 30 cases, more than 2-year follow-up. I had a union in 93.3%. None of the tuberosities I had any resorption or non-union. The constant score average 74 and the American shoulder and elbow score of 75 at 25-month follow-up. I had 2 avascular necrosis, of which one hardly had any symptoms, was tolerating it well, so we conserved. One had complaints of pain, we converted to a hemiarthroplasty. He did well. Why? Because the tuberosities had healed. This is the best part of this implant, that the tuberosities tend to sit anatomically with ease, and therefore they tend to heal well. So as is published in literature by Christian Gerber, that if you have avascular necrosis after a proximal humerus fracture and the tuberosities have healed well, then these patients tend to be functionally quite reasonable and may not warrant any further arthroplasty. So failed Just Unique implant, one is poor selection of patient or a poor surgical technique, and if the implant fixation is not adequate. When would I do a reverse shoulder arthroplasty? Usually in age 70 and above as a primary form of treatment. The point I'm trying to make is the real challenge is in patients who are between below the age of 70, where you do not want to do a hemiarthroplasty or a reverse. You want to preserve the head. Say in patients who are in late 40s, 50s, and 60s, then I think this implant does a wonderful job. Do not take reverse shoulder arthroplasty very casually, because we notice, all of us, that the number of reverse shoulder arthroplasties as a primary form of treatment for proximal humerus fractures is slowly rising. And therefore, this is a warning that in patients below 70, I would think hard before doing a reverse shoulder arthroplasty as a primary form of treatment, because it can lead you to a very difficult, you may end up in a very difficult situation, as you see over here. In conclusion, for displaced 4-part fractures of proximal humerus, particularly in patients where you want to preserve the head, you need to think different. You need to think of Just Unique. Thank you once again, Brazil. Thank you.